Hi, this is Dr. Syed Ahmed. Today we are going to talk about osteomyelitis, an overview of the medical management of osteomyelitis. Bone infection is called osteomyelitis. The infection usually starts in the intermedullary region and is spread to cortical bone and finally reaches the periosteum. In children, usually hematogenous infection seeds the end of the long bones, while in adult patients, hematogenous spread is commonly involving the vertebrae. In hematogenous spread, usually monomicrobial organism is involved, while contiguous spread could be polymicrobial, such as in patients with diabetic foot ulcers. Other type of spread, as we discussed, is contiguous spread of the infection from skin and soft tissue to the bone, leading to osteomyelitis. And as we know, this is commonly seen in diabetic patients. Diagnosis of the osteomyelitis can be made if probe test is positive. If you see an open wound that's especially in a diabetic patient more than 2 by 2 centimeter in size, and if you probe the wound and it reaches the bone, then the probe test is positive and patient most likely has osteomyelitis. No radiographic imaging is required, and we can proceed directly with the bone biopsy. Other modalities of diagnosis of osteomyelitis include MRI without contrast, or we can also do CT scan, which is especially good for diagnosing sequestrum or necrotic bone. Bone scan, three-phase bone scan, is also highly sensitive, but it is not very specific because it may pick up inflammation due to other reasons such as arthritis and degenerative changes or trauma. Bone biopsy is considered as gold standard of diagnosis of osteomyelitis. Bone biopsy does not only provide you histopathologic diagnosis, but you may also isolate the organism causing the osteomyelitis by culture. Now we are going to discuss about treatment. Empiric therapy of osteomyelitis is usually started with vancomycin, because the most common organism involved in most cases of osteomyelitis is Staph aureus or MRSA. Other organisms may be involved, such as gram-negative organisms, E. coli, Serratia, Pseudomonas aeruginosa, etc. Anaerobes or Streptococcus may also be seen, especially in the patients who are diabetic. Other than vancomycin, if the patient is allergic to it or you have to avoid a nephrotoxic agent, especially in patients with chronic renal insufficiency, then the second choice is daptomycin, which is highly effective for the treatment of osteomyelitis. Daptomycin has its own drawbacks and side effects. CPK monitoring is required while the patient is on daptomycin because it can cause rhabdomyolysis, especially in patients who are on a statin therapy. The statins should be held during therapy, or the dose should be reduced, and CPK should be monitored weekly in addition to other labs. Daptomycin has also been associated with interstitial pneumonitis, pulmonary infiltrates, dyspnea, and sometimes has cardiac side effects. If the patient is allergic to daptomycin as well, or for any reason you cannot use it, then next line of therapy is ceftaroline. Ceftaroline is effective against MRSA and most of the gram-positive cocci in organisms. Linezolid is also another choice, but linezolid is rarely used for osteomyelitis. It's not a good drug for osteomyelitis because linezolid is associated with side effects when it's used for longer duration. And since osteomyelitis requires 6 weeks of therapy, therefore linezolid, therefore patients who are on linezolid may end up with some kind of side effects. Neurotoxicity can occur with more than 4 weeks of therapy, and the peripheral neuropathy may be irreversible. Serotonergic syndrome with neuroleptic malignant syndrome may occur with linezolid if the patient is on SSRI. Linezolid was actually discovered as a mild monoamine oxidase inhibitor and was used as antidepressant, and therefore it potentiates SSRI effects. So if the patient is on some of the antidepressants such as Paxil, Celexa, Lexapro, Remeron, Wellbutrin, or Buspar, these medications should be held during therapy with linezolid to avoid any neuroleptic syndrome, which is characterized by altered mental status, agitation, tachypnea, tachycardia, hyperpyrexia, and hypertensive crisis, etc. Newer agents are dalbavancin and oritavancin, which has long half-life. Dalbavancin has a half-life of 14 days, while oritavancin has a half-life of 10 days. These agents are also highly effective for osteomyelitis treatment, but the problem with these longer-acting agents is once it's given and it's in the system, you cannot get rid of it in case if patient develops allergic reaction to it. In these cases, then we end up with admitting the patient in ICU and monitoring him for side effects and using the steroid antihistamines such as Benadryl, etc. These are good medications because these may be given every 2 weeks or 10 days, and patient can be discharged after receiving a single injection. Gram-negative coverage is usually provided with cefepime, which is the drug of first choice, and this can be de-escalated if Pseudomonas aeruginosa is ruled out. If the patient is allergic to cefepime, then other agent that can be used alternatively is azectam or ciprofloxacin. Zosyn is sometimes used, but Zosyn has poor penetration into the CSF and CNS tissue, and in cases of vertebral osteomyelitis, if you are also suspecting epidural abscess and spinal abscess, then cefepime has better penetration. Azectam as well as all the carbapenems also have good CNS penetration and can be used when CNS infection is also a consideration. Now we are going to discuss a little bit about monitoring of therapy. Once the patient is started on empiric therapy and the bone culture is available, and the organism is discovered, then you can use monotherapy or targeted therapy for the osteomyelitis for a total of 6 weeks. If there is no organism that's recovered in culture, then continue both vancomycin and cefepime for a total duration of 6 weeks, because you don't know for sure which organism is causing the infection. Monitoring of therapy can be done clinically, as well as we can check weekly CBC, ESR, and CRP. Now let's talk about osteomyelitis with retained hardware. If a patient has hardware in place and osteomyelitis is because of certain aggressive organisms such as Staph aureus, MRSA, Pseudomonas aeruginosa, or Stenotrophomonas, or fungal infection, then in those cases hardware removal is necessary. Otherwise the infection will return back. If you cannot remove the hardware, then in that case buying time with rifampin therapy, which provides penetration of the biofilm that's formed by Staph aureus and gram-positive organisms. Rifampin basically drills holes into those layers and those layers of the biofilm, and facilitates the penetration of vancomycin and daptomycin into the bone tissues. If the hardware cannot be removed, rifampin should be continued with a dose of 600 milligrams once daily, or it can also be used as 300 milligrams BID along with one anti-MRSA medication such as vancomycin, daptomycin, ceftaroline, etc. Rifampin should never be used alone for Staph aureus or MRSA infection. Now we are going to talk about the duration of therapy. The duration of therapy, as we discussed earlier, for osteomyelitis is 6 weeks, unless patient has vertebral osteomyelitis, in which case 8 weeks of therapy is recommended. If the patient has